Hi, everyone. Welcome to Jaw Talk. I'm your host, Dr. Tiffany Lamberton. Today, I'm so excited about our guest, Dr. Annie Babb. She's a dentist that's passionate about more than just fixing smiles. She's a transformative force in the realm of airway dentistry, myofunctional therapy, and functional frenuloplasty. Dr. Annie has practiced general dentistry since 2011. She's always been interested in the whole body connection and found her passion in airway dentistry. She's determined to help children and adults develop to their fullest potential by encouraging proper breathing, tongue position, and facial muscle function. She believes in a collaborative approach and works closely with other providers in the community to help our patients get the best results, not only for their smiles, but their current and future health as well. Dr. Annie began taking countless hours of continuing education on myofunctional therapy and tethered oral tissue with some of the highest regarded doctors and professionals in this field, including Dr. Zaghi, Dr. Baxter, and Sarah Hornsby. In early 2021, she became an ambassador for the Breathe Institute and decided to limit her practice to performing functional frenuloplasties and frenectomies. So tune in to our conversation here as Dr. Annie generously shares her wealth of knowledge and extensive experience. Quick legal disclaimer: all information in this podcast is the opinion of the speakers and not meant to be a substitute for a diagnosis and consultation of a qualified healthcare provider. Hi, everyone. This is Dr. Tiffany Lamberton of TMD Collective, and I am so excited this morning to talk to my guest, Dr. Annie Babb. I was just telling her before we started recording, I've been pretty much fangirling her on Instagram and just kind of watching a little bit of your journey of how you kind of got into tethered oral tissue and myofunctional therapy as a general dentist. So welcome to the show. Thank you so much for being on with me this morning.
Yeah, thank you so much for having me. I'm so excited, and it's always great to talk to like-minded practitioners and just kind of chat. So I'm excited.
Yes. Well, tell us kind of like your journey of like, how did you go into dentistry and then into kind of like where you are now? Kind of tell us a little bit about what you're passionate about.
Okay, so my dad was a dentist. He's retired now, but I grew up, being obviously very exposed to dentistry and just really loved it. And then when I was in high school, I also kind of got interested in physical therapy. So I think that's a really neat connection. And when I went to college, I was kind of between the two, and then ended up going into dentistry because, I had my dad and I thought that'd be really nice to work with him. So I worked with him for almost 10 years after graduating. And then he was kind of getting close to retirement age. And I don't know, I just didn't really have it in me at that point. I didn't feel like taking over the practice was what I really wanted. And I always thought, that was always the plan for him, for me. And so that was kind of a pretty tough realization and a hard conversation to have with him. But I did it, and we ended up selling the practice, and I was working just one day a week for the new dentist, and we got along great, but I had a lot of time to kind of do some research, and I was having some, I would say, airway issues of my own when I was running, and I just noticed I was always kind of out of breath, no matter how good of shape I was in. And so I asked the orthodontist that I now work with, hey, you have an ICAT, you can see my airway on there, right? And so we looked at it, and she's like, it's really small. Well, what do I do? She's like, well, go see the ENT. I'm like, I already did, And so I talked to one of my good friends from dental school, and she had recently kind of gotten into the airway world, and she suggested I go and see Dr. Lipskis, who is an orthodontist in Illinois. And I went to go talk to him, and it was very eye-opening. And in my research, I realized all these issues I was having were possibly related to the fact that I was tongue-tied. And I grew up knowing that, but I didn't have speech issues. And so we didn't do anything about it. That's what we were taught in school. There's no reason to treat a tongue tie unless they're having speech issues, pretty much, or very obvious feeding issues. So then I'm researching more and realize, oh my gosh, my daughter has all of these same things. I had a really difficult time nursing her. She was just a disgruntled baby, I would say, colicky symptoms and all those things. So then that propelled me even more to kind of learn more. And I was talking to Dr. Brenda about it, and she's like, well, I want to learn. Tell me, how Dr. Lipskis is treating you. So she ended up taking courses under him, and then kind of brought that back to our community. And it just really snowballed. I mean, when I first started talking to her, I'm like, I think I want to do tongue releases. I think this is why I didn't take over my dad's practice. This is what I want to do. And she's like, great, come do it at my practice. And we kind of didn't at that point in time know how connected ortho and tongue tie was. It was just kind of like serendipitous. And then the more we learned, we're like, oh my gosh, like this is a great combination of skill basically. And then I took a myofunctional therapy course. And so I brought that into the practice too. And so it's really just evolved from there. So
yeah. Where did you do your myofunctional therapy course? Was that through the Breathe Institute, or was that AOMT, or which?
So I did it through Sarah Hornsby, and she is somewhat, I believe, was kind of affiliated with the Breathe Institute at one point. I'm unsure because they work pretty closely together though. So I did it through her, and it was a 3-month course, which I really liked. We met twice a week, and I felt like the pace of learning was really good because you could apply what you were learning to, situations. It was just easier to take in, I feel. And so then I ended up hiring, now we have 4 myofunctional therapists. And
wow,
so
that is so cool.
they're all hygienists, and they've all taken her course. And then I've got a couple of them who are going to work probably with some of our younger patients. They are also going to take Hallie Bulkin's course as well. So trying to get, a little bit of an SLP perspective on it, always very careful to stay within, what's our scope, but to see kind of how she teaches and some of the methodology, hopefully, bringing some of that to the practice too.
Yeah, that's so cool. When I spoke this last November at the Pacific Northwest Dental Convention, which is kind of our big Washington state meeting, Sarah spoke there as well. So I was able to kind of catch her lecture. And then it was just like we were both kind of mobbed by dental hygienists that were like, how do we get into OMT? Like, where should we start? Like, I think it's really interesting to hear, kind of the different perspectives and kind of like who has the best educational programs. So I did, a little bit of work through like the AOMT, and I feel like they have a solid program as well. But it's, I've had Hallie on the show, and I think she's got a really solid program as well. And like you said, the SLP connection is really cool because they're able to kind of already be addressing like, some of the feeding issues and the swallow, and, their patient population is, definitely a younger age than like what I'm seeing in my practice. So I'm like, okay.
Yeah. Very different perspective for the little ones. You're geared so much more towards prevention in them than with the older patients where you've already got issues, because they've been living this way for so long and they've had these compensation patterns for so long. It's neat to be able to kind of be in with that younger population. I see babies now too for infant releases, and it's a totally different thing working with the babies versus the older kids. And we're trying to kind of bridge that gap too between infants. I'll see them pretty much 1 and under. And then after that, you kind of have like, we're calling it like these gap years where those are the difficult cases to treat because you want to intervene. So much growth is happening, but you're also really limited in terms of what you can accomplish with, of course, myo, but even, orthodontically, they're tiny, and you are trying to find the best way to get them on the right path. And so that's something that we're trying to focus on a bit more in the practice, is starting to see those ortho patients younger and really capitalize on their growth. So,
yeah. Tell me a little bit about like how you did like a residency with Dr. Zaghi. Tell me a little bit about how that evolved.
Yeah, so I'm not a Breathe affiliate. They have Dr. Zaghi come to their practice. So they shadow him in his office and then he will come to theirs. So I haven't done the affiliateship, but I've taken the Breathe course twice. And then I also took the Breathe Baby course. So I took the Breathe course twice, and then I went out and shadowed Dr. Zaghi for a day last year and watched him do surgeries. And then he actually did my tongue release and then also my daughter's, which was really neat to kind of sit chairside with him while he did my daughter's release, and just an amazing experience. The whole day I was just like, this is the coolest thing I've ever done. It was just so neat to be there and see them in action. I think very highly of everything that they do, and that he works so much to get research, and he's just always about learning more and changing and being better, and just everything that they, stand upon and do. I'm just in awe of, and try to model as much as I can after, that methodology and that the way that they approach everything from patient care and how they interact with patients. And they do it right.
Yeah. How was that like as a mom, kind of like watching your daughter go through that? Was it emotional or was it more like exciting?
It was exciting. So my daughter Gracie she's really into all of this, which is so cute to see. Like she'll be watching a show and she's like, Mom, I think they have a tongue tie. And she's usually pretty on. Like she's heard me talk about it, and I think she can feel my passion. And so she's real into it. So it was really fun because she wasn't afraid. Like she was excited. This was a big journey for her. And she knew like how amazing it was to have Dr. Zaghi be the one to do the release. And so she was just all into it. So I wasn't really nervous. It was more just exciting to see the changes in her, and just even the changes from her going through ortho and working with me, doing some of her myofunctional therapy, where she's at now compared to where she was when she was little. She's grown so much. She was just such a difficult toddler and never really slept well. Now she sleeps through the night. She's doing so much better. So yeah, really I don't know. It wasn't emotional in a bad way. It was just exciting for her that she got to be part of something so neat.
I love that. And then tell me a little bit about how you got started with, using laser as part of that. Did you go through some separate training through American Laser Society, or like, how did you get started with that?
First, I took kind of a local course just to see if I was even interested in doing functional frenuloplasties and kind of what that would entail. And got really into it from there. And so then I took Dr. Baxter's course, which was online. This was all kind of during the height of COVID. So everything was online at that point. So I did Dr. Baxter's course, and then I did the Breathe course. And both Dr. Baxter and Dr. Zaghi are big proponents of using the light scalpel. So it was kind of like no question, that's what I was going to use. Everything I learned about it, I'm like, this is the right tool. It has the best of both worlds in terms of cutting, coagulation, and being so gentle to the tissue. So I just did some work directly with light scalpel. When they came in with the laser, they trained kind of on the spot for me. Again, it was kind of a unique time with COVID. So that's how I started. So I never actually had used any other type of laser besides light scalpel. So I have nothing really to compare it to, but I honestly can't imagine using anything different. It's just such a great instrument. And I feel like my patients heal really beautifully. It's just so gentle, and it works quick, and it's really pretty painless after for them too. Granted, that's also partially because they're doing their myofunctional therapy, so they're very well prepared for the procedures. But in the infants, they heal beautifully. Parents usually say maybe that first day they're kind of uncomfortable, and then they do really well. And that's pretty much the same for the older kids. It's one day of quite a lot of discomfort, and then the parents are always surprised. They're like, they were better. After that, it was pretty good. So I love my light scalpel.
Yeah.
Can't imagine working without it.
Yeah. Yeah. What advice would you have to someone who's like kind of shopping for a laser and just trying to decide?
Yeah, look into the light scalpel. Depending on what you need, I'm not doing any hard tissue laser dentistry. I only do lip and tongue tie releases. And then, obviously I started our myofunctional therapy program. So I did do myofunctional therapy for a while, but I don't do that anymore. I just kind of oversee. So for me, I just wanted a laser that was going to be good for what I needed, which was not doing any fillings or anything like that. And so I know there are some providers who like some of the other lasers that also do hard tissue. I think with doing functional frenuloplasties, this is just ideal because of everything I said about, coagulation plus, quick cutting, low thermal damage. It just works really nicely, and the patients just respond so well. So definitely look into light scalpel, but learn about the laser mechanics, learn about why one may be better in a certain situation than another, because they all have different times where maybe one laser would work better in a certain situation. And so you kind of have to take that education upon yourself. The American Laser Study Club has a lot of information to look at too. And just light scalpel, anything they produce, they often have information about like the laser specifics and why you would use one over another in a certain situation.
Tell me a little bit about how you kind of created, this amazing practice with Dr. Brenda and, your myofunctional therapist. You alluded to that, kind of like where you are now, but tell me a little bit about how that all kind of came together where you're collaborating and working out of the same office.
I took the first course that I was like, yep, this is what I want to do. I want to do, frenuloplasties. This is it for me. And I think because it combines dentistry and there's so much of, physical therapy involved with myofunctional therapy, it's just kind of a combination of like the two parts of my brain that I'm really passionate about. So when I went to her and I was like, this is it. And, we were trying to figure out, okay, how would that look if I do it in her practice? And then the more we both learned about it, like this is so important to be able to offer kind of together for our patients. And, before I do tongue releases, they need to have myofunctional therapy. So how are we going to handle that? Which first it was me doing the myo, and then we've slowly brought more and more hygienists in. So when it started, I did the myofunctional therapy for any orthodontic patient that we felt needed a tongue release. And so it just kind of started from there. And then I would say in about a year, we decided, okay, really all of these ortho patients need myofunctional therapy. That's a huge part of why they're in ortho to begin with, is their tongue function. They're not in balanced function, and that's going to help our ortho cases. And so then we brought in some more therapists, and now myo is a part of every ortho patient we see. So they come in for an orthodontic consult, and we have a great treatment coordinator who is so good at educating our patients on why this is our methodology. And so they come in, they typically are in expansion. A lot of them are in protraction too. So bringing the upper jaw forward and also getting it wide. And the way we explain it to patients is, if your tongue was up in the roof of your mouth when you were developing, your palate would be wide, your jaws would grow forward. So we have to use ortho to get them where they would be at their genetic best, basically. So we kind of start the process with expansion. And then when they're getting close to having those appliances removed, then they start with our myofunctional therapy team, and they meet for a really thorough assessment. And then we get them working on nasal breathing and tongue posture up. If they need a tongue release, they see me about 2 months later, and then they continue with their myo, and then they finish up their ortho. So it's pretty seamless now. It was not seamless to start. It was a lot to figure out, like, how are we going to bring all this and make it flow for our patients and not burn them out? And, what's the best way to kind of combine it and overlap as much as we can? Because you don't want somebody in treatment for 5 years. That's not realistic. And so really trying to be real world about what we can accomplish. And so I would say now it flows really, really nicely. And I think, we're always learning and we're always modifying. But from where it started, where it was just, okay, how are we gonna bring it in to where we are now, and then also now that I see the babies, that's a whole nother arm of the practice that we just kind of started more recently. So it just evolved in the last couple of years.
I love that. And are you finding that you're moving towards kind of more of like a fee for service model, just because it's not well covered by insurance? And
Yeah, yes. So we are fee for service, and that's sometimes difficult to explain to patients. For my side of things, I will send to dental insurance for the older kids, and then for the babies, I will give the parents a medical super bill so they can try to get reimbursement. And sometimes they do, and sometimes they don't. And we're just pretty upfront about it. It kind of falls in this no man's land of, especially the releases specifically. Dental insurance doesn't always want to cover it, and medical insurance doesn't always want to cover it, and they want the other one too. But I think when they come in for that ortho consult and they see it all, we take an iCat on them, we take posture pictures, we take all these things, and, we kind of put it together for them. I think it's hard for the parents to unsee it, and they're usually on board. And often we're the first providers that have really heard what the parent is saying and give them a solution that's not medication. Or so once they're in and they hear why and they see it specifically in their child, they're really thankful. But yeah, fee for service is pretty much the way we've handled it. So
yeah. Well, and that's what I'm doing right now. I mean, I have a small like TMD kind of airway only practice. And, I just tell my patients like, TMD, TMJ issues, it's kind of this gray area between medicine and dentistry. It's not really well covered by either. I'm a solo practice. So like, I just can't, I can't wrap my head around the insurance part of it. So
No, I feel the same way. It's just, and even for Myo too, I mean, the insurance is, the coverage is all over the place, and it's, insurance companies just dictate so much. And I think that in a situation like this, I don't want to be dictated by what insurance will or will not cover. I want to do what's best for the patient. So we kind of explain it that way too.
I love that you're really creating value to your patients in that diagnostic, with your diagnostic records, with your photos, with your CBCT, like really like showing them the anatomy and the images. I think it's such a powerful tool.
Yeah, I think that it's been very helpful for the parents to see it. And I think, we've had a lot of parents say, like, I've learned so much. I've learned more coming in for all their different appointments here than I've learned in a long time or I've ever learned about the human body and the connection. And that's so rewarding to be able to educate. That's a huge part, I think, about this kind of part of dentistry is there's so much educating to be done. And I love to educate. So that's been really fun to be able to be that one that can help the parents and say, let me piece this together for you. And then also just being able to collaborate with so many different providers in the community. That's been so neat, to be able to work with PTs, with SLPs, with you name it, basically. We work with them and to be able to learn from one another, it's just neat. I'm always learning, and that's
Yeah.
really fun for me.
I love that too. I just, I think that you've got to have that PT perspective because it's not just not, like the rib two and up. It's, your whole, like the fascial planes and the fascial systems. And, then from my PT perspective, I love that, you're doing kind of that postural retraining and you're looking at habits, maybe oral habit elimination and all of those things I think are so important. And I think that, I love that we have the tools of modern imaging that we can start to really like see that underlying skeletal scaffolding really and, kind of start to direct that growth. I think it's so exciting.
Yeah, that is one of the neatest parts, I think, for me. And again, probably because I've always just loved physical therapy and I love the muscles and how the body moves and everything about it is just fascinating to me. To see the postural improvements in the patients. And sometimes it's not always patients that need a tongue release. Like sometimes it's just opening up their airway and then their ability to stand more upright and not have that forward head posture and then the anterior pelvic tilt that follows, and to just watch their posture improve from expansion and protraction alone. But then especially when I do releases, it's almost instant. And that is so neat. They get up out of the chair and you can tell like, oh my gosh, their shoulders are down and they're not hunched like this. And they can feel it too. Mostly I'm working on kids. And so some of them are more body aware than others, but the ones who are body aware, even during the release, I'll say, how's your body feeling? Like I want to check in with them so that they're also acknowledging what's happening, that it's not a shock to them, because that can be really jarring to go from feeling a certain way to all of a sudden your body is positioned differently. So I kind of ask them throughout, and some of them will say like, I felt that. I felt my arm feels different or my legs feel different. And so that is just the coolest. I mean, it never ceases to amaze me. Like I get so excited about it whenever it happens. Like it's the first time I've ever seen it and I see it all the time, but it's just exciting for those kids. And they come back not only standing more upright, but they just have like an air of confidence about them that they didn't have before. And that is also very cool. We see them at the 1 week post-op and some of them are like, are you even the same kid I saw a week ago? In a week, the transformation from better sleep, and they can, often talk louder. They're not mumbling as much. And so they just carry themselves totally different. It's cool to see.
I know I've like just kind of like waffled a little bit with one of my own kiddos because, we've done some airway intervention and, he's kind of like right on the border of like a grade 3. And, now I'm just like, well, maybe it's like, because when we did his tonsils and adenoids at 7, the ENT came running out to the lobby and was like, do you want me to do his tongue too? And I'm like, no, wait, I haven't like done all like the preparation and like, kind of like the myo before and after. And so we've done, kind of some myo, but I think that, that could still be like a piece of the puzzle. It's like now he's starting to, go into ortho.
I think I always say with the patients who are kind of in between, because it's not always black and white. I wish it was. It'd be easier for me to make decisions sometimes, but it's not. There's a lot of gray and it's different in every patient. And so I always tell the parents in those cases, like, let's see how they do. We want to see improvement with expansion and protraction, symptom improvement. We want to see even more symptom improvement when we start working on tongue function and compensation patterns and those kinds of things. And let's see where they're at after that. And if we still don't have great symptom resolution, then let's consider more strongly doing a tongue release. There are definitely ones where I see them at the beginning because I typically do a lip release early on in treatment when we're doing protraction to kind of help assist moving things forward, release some of that tension that's holding things back. So I often see them early for the lip and then I will assess the tongue then. And sometimes I can say, yes, you're going to need a tongue release. There's so much tension in here. There's no way you're going to have full function, but sometimes I can't. And so those, I really look at the symptoms and I tell the parents too, like it's so individual, how is your child functioning? Because some may function well and fine and have no symptoms. Then I'm not going to push to do a surgery on a child who's not having symptoms, just because the tissue looks or feels a certain way. Now, obviously, there's caveats to that. If it's really restricted, I think often there's symptoms they don't realize. And a lot of that is more in like the joint and the kids just don't have pain there yet. But I know they're compensating with all those muscles that surround the joint. You can just tell, But often I kind of leave it up to the parents and the child too. Like I want them to want it. And if they think that there's enough symptoms for them that warrants doing a release, then we do it. And I'm often really surprised at how profound those results can be. But it helps for them to be paying attention. What in my body is this affecting? And that kind of gets them more on board too. I never want somebody to feel like I'm just saying, you need this, listen to me. You need it because I tell you need it. I want them to know why they need it and to think they need it too.
Absolutely. So what about in like the patient, let's say like you've done a lot of like, work in the transverse plane, but like there's still like a mismatch in that AP direction. So maybe like the mandible is still like pretty retrognathic and, pretty class 2, maybe anterior open bite. And you're still seeing that it's kind of still like locked back. Like what are some of the things that you're thinking at that point?
Yeah, so historically, Dr. Brenda has used a Herbst, and we're trying to kind of move away from the Herbst. It works, but there's, ideally we'd like to do it without it. So we actually work with a lot of chiropractors too. And so we've been kind of exploring more, how can we help like relax the musculature around the joint to help that jaw naturally come forward? Because if you think about it, if you've got the maxilla forward enough, the lower jaw is going to want to come forward into a more favorable joint position. It's more comfortable. You see a lot of these patients where their lower jaw is shoved back into the condyle, right? So if you free up the space, it wants to come forward if the muscles are relaxed, if there's no bite interference or anything. So we've actually started to see, even after tongue releases, how much the mandible will start to move forward on its own. I think that kind of backward pull all the time is part of what keeps it back. So we've seen it slowly come forward. It's slow though. And so that's still kind of an area that we're trying to figure out, and it's different with every patient, the needs are different. But I did have one very recently where that was the mom's main concern for her child, was the mandible being so retrognathic. And, she asked me, is it going to come forward? And I said, it should, for all the reasons I just stated. Mm-hmm. And he came in at the week post-op and she's like, it's already more forward. Like, you're absolutely right. It is already at a week. So kind of combining all the things and combining myo with that to help relax the muscles too, and to get the muscles functioning. we found a lot of the jaws will come forward. It's just not always super fast, but sometimes it's faster than we think.
Well, one of the things that I try to also provide is if I'm getting like, let's say maybe like a 12-year-old female that has kind of gone through some of this intervention, but is like still having some issues, looking at, again, both the CBCT, but sometimes also getting like an MRI of the TM joints and just
Mm-hmm.
making sure that articular disc is, and, the disc system with the ligaments is still kind of protecting like the growth center of the condyle. And so I use, a protocol that I learned from a couple of my mentors, Dr. Drew McDonald. I don't know if you've ever heard him speak. He's a colleague of mine in Albuquerque, New Mexico. And, he's an orthodontist that we're also kind of pulling in some of that MRI imaging of the TM joints and just seeing like, okay, that forward position that we want to get there with ortho, do we have disc coverage in that position before growth has been completed? And so that I think has been like a really important tool for me to, kind of like try to bring that information as a general dentist to like the orthodontist in my area, like, hey, this might be like another piece of the puzzle that maybe could be like part of that, because so like for my own kiddo, he had like kind of a series of different things, like fell on the chin and like fell on, in kindergarten on the playground, and then fell like a month later at the same exact spot in the playground, like stitches and concussion and like, and so when we tried to do his MRI initially, he totally freaked out, and then I was just like, oh my gosh, I'm the worst mom in the world. Like he hit the panic button and he's crying and I'm crying. So then he got a little bit older and, we had done some other things and, kind of revisited that. And sure enough, kind of the side where we were seeing the growth deficiency where, short mandibular ramus, more class 2, both like the maxilla and the mandible were deficient compared to the other side. That was the side that had kind of more of that disc displacement. And so, what we're trying to do with like more of like a removable functional appliance is, same thing as like a herbs, but just knowing that we've got the disc coverage in that particular position. And then that's where, we can start to like build that tripod of, the occlusion. But I mean, I'm also like a huge proponent of like looking at C1, C2 and, like the atlas rotation. And like you said, a lot of the muscular, myofascial components will like hold that growth back as well. So I think it's super exciting.
Yeah, I feel like there's so much to learn about the mandible and its positioning and
Yeah.
what we can do to get it to move. And that's such an interesting perspective too. I know Dr. Donko, I don't know if you've
Yeah,
heard.
we're in the
Yeah.
same study club. Yeah,
Okay.
I love her.
So she does a lot on that. She's done a lot of like her own research on that. And I listened to her actually on Hallie's podcast, and it was so fascinating to me because that's definitely something I don't know that much about. Of course we all look at it from
Like
our
a
specific
different lens.
lens.
Yeah.
Yes. And for me, I'm like, okay, how is the tongue position and the tongue tension? How is that affecting the mandible position? But there's so much more to it. And it's, again, that's the beauty of this whole area is learning from each other. And I feel like everybody's so open to learn from one another and
Yes.
really put our brains together, which is cool.
Yeah, no, I love that. And my little favorite graphic that I kind of came up for TMD Collective was just like Airway plus Myo plus TMJ, because I think if we lose sight of one piece of that triangle, then we're kind of like missing a whole, part of the picture. But, I think that there's so many barriers along the way. It's just like even talking to like a pediatric dentist about like doing a CBCT scan, I mean, even though it's a low radiation, I have dentists in my area that are like, oh, no, 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 I could never, do that. And it's like, it's combined with like our comprehensive exam, right? And yes, be judicious with our imaging, and yes, but I think that if you're just ignoring the issue or like approaching this like let's wait until like the problems develop. It's like, why are we waiting until symptoms develop, And to me with TMJ, same thing, like why are we waiting till the patient has clicking and popping and pain and headaches? Why aren't we guiding it when they're at that kind of younger malleable stage where we can really make a difference?
Right, for sure. I agree completely. And trying to get them onto that right growth process. The younger you get, the less issues they're going to have down the line. Or, hopefully, obviously there's different things that can happen. Like you said, I mean, falls, different things, but giving them the best chance by teaching them young and not just intervening with orthodontics, but really teaching them the parts that they can control in their own body, keeping their tongue up, breathing through their nose, not through their mouth, like all these little things, the more you teach the kids, like they pick up on it. And I think that's rewarding to be able to intervene when they're young, to hopefully prevent them from having some of these issues that, so many of us, I think, in our generation are dealing with because we had ortho, but we didn't have ortho looking at why we needed it in the first place, So I think even TMJ issues from that, depending on what type of orthodontics patients had, if they had extractions and retraction, I mean, I'm sure you have a lot of those
I
patients.
had it here. My dad was a dentist, so
Yeah.
just like let's cram the maxilla back and
Yep, exactly. I mean, but that's what they knew. That was what they were taught then. And we always kind of say in our office, which is I think a pretty common quote, is do the best you can until you know better. And when you know better, do better. And we can't get too upset about what we did in the past because we just didn't know that. And, we're always trying to do the best we can for our patients. And so continuing to learn and talk to other providers in different fields and really being open and putting egos aside and trying to just do the best we can for our patients is the goal of so many in this area.
Absolutely. Yeah. I love that. Well, and I think there's just, there's a huge controversy right now of like, did 4 premolar extractions cause apnea? Well, first of all, like apnea is a very complex topic. There can be, so many different kinds of apnea, and there can still be sleep related breathing disorders without, full apnea. And, my thoughts are like, if we're taking out teeth to, fit the teeth together, I still feel like it doesn't do the airway any favors.
Right.
And it doesn't, you see these patients later on that, like you said, you have the very like high vaulted, narrow maxilla. There's not enough room. Their tongue is kind of just pushing forward. It's like they don't have a home for their tongue. So it's like, is it that their tongue is, is it macroglossia, or is it that there's just very narrow jaws? So,
Right. And I try to explain to our patients too, there's so many factors to why the jaw is narrow. It's not just tongue posture. That's a huge, huge component of it, but it's also our diets. We eat soft foods now, a lot of soft foods. We're not challenged with those hard foods that help stimulate the jaw growth either. So you've got kind of a twofold thing going on. Well, it's more than twofold, but those are two of the biggest things. And so you end up with these small jaws that can't house those teeth, but then you take the teeth out and you just make the jaws smaller and you're just pushing everything back and compressing that airway more. So, is that what came first, where they're probably already predisposed to have sleep disorder breathing because they have low tongue posture. That's why they're narrow. It's just like this vicious cycle that then it just kind of keeps self-propelling unless you intervene. So I tell parents that too. I'm like, something as minor and seemingly harmless as mouth breathing, we see it everywhere. That is setting the stage for your child's growth and development. It sounds so dramatic, but it's really not. Like, you need that muscle of the tongue growing everything the way it's supposed to. And if you don't, you're setting the stage for more problems because you're going to have small jaws, but then you're also going to have no space for the tongue, low tongue tone. Like, it's just downward spiral, basically.
yeah. Yeah. Well, and I think that, as dentists, we have the opportunity to really impact that oral pharyngeal airway space. The nasal part of it may be, more ENT related, but even just getting like ENTs on board with like, hey, we see in our scans the patient has a deviated nasal septum, like they're having these issues. I just sent a patient to an ENT who I thought was like on my team. And, it was just like, he was super dismissive of my patient. And I was like, I just sent you the scan. I sent you the report. Like, and you're just telling her, you need to lose weight. Here's a card of like a weight loss doctor. And I was like, oh, I mean, you just, like you work hard to build those relationships in the community. And I'm such a proponent of like interdisciplinary care. But when we're seeing these things, that's like, I can't do nasal surgery, but this patient I think would really benefit from these interventions. I mean, it's not necessarily my call on what they choose,
Right.
but it's part of like her whole like, chronic pain issue and sympathetic nervous system, and where she's having nightmares at night. And
Yeah, for sure. And we tell our patients too, like, listen, if you can't breathe through your nose, if you have a structural problem with your nose, nothing we do is going to like overcome that. You have to be able to breathe through your nose to do all these other things and to really get the full benefit. It's so hard. It's so hard with the ENTs. I've got one that I've been kind of talking to, and we just recently agreed on one case. I was like, okay, that's a win, but I think again, their training, they're not looking at all of those things and kind of the trickle down effect, not because I think just because they don't know, they haven't learned how it's all connected, or they haven't thought about it or whatever. Because I had a kid with a severely deviated septum, and trying to find an ENT who will do it. Like, it's all the way to one side. Like, how is that okay? Like, that's going to cause so many issues down the road for this kid in terms of how they're going to develop facially, because they can't breathe, but also because they can only breathe through one side. Like, that is probably the hardest group. I'd say ENTs, and then pediatricians too are pretty tough for me. I feel like outside of that, I've got a great collaborative group, but
yeah, I love that.
I think they're coming around though. I think it's getting better. I would say even in the last maybe 6 months or so, I think there's been more openness, at least from in my area. So
yeah. Tell us like what you're doing in the education part. Are you doing some like local study clubs, or like tell me about kind of like what you have going on in your area?
So I don't have a study club. That's a great idea, and I should probably start one. But I actually just recently gave a presentation. One of the chiropractors that we work with, he does DNS, and he just does a lot with like diaphragmatic breathing and proper all of that. A lot of full body looks at breathing. So a lot of the people that take that course were interested in, how ties impact.
Is it like breathing mechanics or?
Yeah, breathing mechanics, plus a lot more. He does all kinds of things. He's also trained in the Scroth technique too. So he works with patients with scoliosis. So he sees a lot of more of the whole body impact. And so he's been trying to tell some of the people about how ties can be impacting all of that function too. So he asked me to speak before his most recent course. So I did that, and then I'm going to speak again in December for him. And then our office is having a course in October. So we actually are just now putting together like all the different providers we want to invite. And we've done one before where we had dentists and hygienists. And this one, we're going to try to focus more on collaborative care providers. So providers in different fields, not dentistry, so that we can kind of discuss the methodology behind why we do what we do, and kind of the role that each of them can play in that. So yeah, no study group yet, but just kind of different speaking events. I am in a group that is a lot of different types of providers. It's a pediatric, I forget the formal name of it because we've changed it a few different times, but it's pediatric providers. And so we will take turns kind of lecturing on our specific topic. And so then that's been a neat group. So that's an SLP started it, and there's a pediatric PT, a handful of SLPs, some OTs, My myotherapist comes sometimes, lactation consultants. So that's a really neat group.
Well, you should join our Chicago study club that Dr. Courtney and I are a part of. We're going to have some orthodontists come in October. It's always like twice a year. It's kind of more, I mean, it is like a lot of restorative dentists too, which for me, like, I'm like, I don't want to do restorative dentistry anymore. But I think that they do bring in a lot of, kind of the growth and development piece of it. And it's just a really fun group of people. So if you're interested, you could come be my guest.
Yeah, I would love that. Send me the information and
I
yeah,
will.
always
Yeah.
looking for new ways to learn and new people to connect with. So that
Yeah.
would be awesome.
Yeah. Well, like I said, Dr. Courtney is part of that group, and we're going to be meeting, I think, like the third week of October in Chicago. And it's always just like a fun group to get
Yeah.
together and just hear different perspectives. So, but I
Yeah,
love
that'd be awesome. Definitely send me the info.
Yeah. Okay. All right. Well, thank you so much for taking the time to talk to me this morning. I just love what you're doing. I love your business model. I love that you're bringing women together to really like create kind of like a new space for dentistry, because I think as moms we, face a lot of different challenges of like juggling the puppy and the kids and like the carpool and all of those things. And sometimes we, just having like a full practice can, it's nice to be able to kind of share that with other like-minded practitioners. So I think what you're doing is so cool, and I'm really just excited to hear more about like how you guys are evolving. So keep me in the loop for sure.
Yeah, thanks. And I feel the same about you. I mean, it's nice to find a group, like you said, of women who have similar goals and you can kind of share the load. And I think with general dentistry, you wear a lot of hats. And I think that's been nice to kind of focus my professional hat on one thing. That's been good for me. Like I don't have to be the one to know all the things. I know this thing. And I'm with a group where, Dr. Brenda knows the ortho part and my myotherapists know the myo part. And then we've got providers outside that I can send to. I think it's just been good for my mental health too, to not have to be like the one that knows all the different components. So
Well, and it's just such an area that at least I feel like I got nothing in dental school about. And so I think, as we're seeing like new generation of dentists come out, I think they're also like hungry for information and wanting to see like, how do you incorporate that into your practice? And, for me, when I started to get into Airway, I was like, wait a minute, we can't just throw people into like MADs and just pull their jaw forward without really like knowing the whole picture. We have to have kind of that bigger lens of looking at things. So I think just educating other providers is really exciting.
yes, I agree completely. There's so much more to learn, but it's fun to be on the path, and be part of all of it.
Well, thank you again. It was such a pleasure to talk to you. And, like if you have anything that you want to promote or, where people can find you, we can include all of that in the show notes. There you have it. Another fabulous episode of Jaw Talk with Dr. Tiffany. I'm so honored that Dr. Annie Babb could join me on the show today. What an amazing conversation. Remember to give us a 5-star review on whatever podcast platform you consume your podcasts on. If you like the show, please consider a paid subscription to Patreon. Thanks again for listening. Until next time, stay humble, stay curious.